that we cannot completely cure. Let's say a person comes to us with a stroke or a head injury and they have actually gone through the acute care. Now what happens to them in the post-acute care? We often refer to them for physiotherapy or occupational therapy. Now is this concept of rehabilitating these patients, is it scientific? Are there ways by which we can bring them to realize themselves and mainstream them into society? Now that is what is rehabilitation medicine. It's actually the third phase of medical care. We all know that preventive and curative medicine are the very popularly and well-known fields in medicine. Today, the quality of life is becoming very important. We have an aging population, people with osteoarthritis of the knee, people with Parkinsonism, people with age-related problems of the brain. All these patients come to us expecting a better quality of life, and rehabilitation medicine is the one that medical professionals can contribute in a great way. Now when I say medical professional, we are called physiatrists, and let's not confuse that with psychiatrists, though the spelling is very similar. But what we do is we treat by physical means mostly. The common approach when we see a patient is to reach out for a prescription pad or to prescribe surgery. But there is also a third model of treatment, and that is the physical modality. This does not go to say that we don't do surgery or we don't prescribe medicines. We do all those things. In fact, interventional physical medicine is becoming very popular these days. But by and large, our management is towards pain relief and towards paralysis. Sometimes both go hand in hand in some conditions, and our area is mostly bringing in that back to as near normal as possible. This is not possible totally just by one person, one individual. So essentially a physical medicine specialist needs to be a leader, needs to be a team worker, and the professionals that he works with are the physiotherapist, the occupational therapist, the social worker, the psychologist, the speech therapist, sometimes an architect, a biomedical engineer. All these people constitute the rehabilitation team. Rehabilitation need not just be medical. Let's not feel that, okay, the patient comes to you, we prescribe something for them and they get back. No. We need to follow through these patients in their domestic milieu, sometimes in their place of work, and see how they are coping with their disability. Now, disability is something that is not very much evident in society around us, because disabled people generally are marginalized. They don't come into mainstream society, but they are out there. An estimated 7 to 10% of our population is disabled, and many of them locomotor. How did I get interested in physical medicine? Well, actually, in my final year of medicine, we were asked to make our rounds in the wards, and when I was going around in neurology, we used to see there's a case of hemiplegia, a case of Parkinsonism, a case of head injury, a case of demyelinating disease, and so on. And many of the case sheets were very detailed and very nice, nicely investigated, but there was a part of the prescription that said physiotherapy or occupational therapy, and I got interested and said, okay, is physiotherapy and occupational therapy? There must be somebody who, from the from the evaluating side, who knows what is going on there. So that got me into physical medicine. We are not physiotherapists. Having done our MBBS, we do our MD, and there are several institutions offering these courses today. Back in 1988, when I did the course, there were very few institutions. Even today, there are probably 15 to 20 all over the country. In Tamil Nadu, we have the institute in you can edit?
Yeah, you can edit, yeah.
In Tamil Nadu alone, we have in Vellore and Chennai, and also in Chidambaram, institutes offering training today in rehab, and there are certain premier institutes all over the country, like in the All India Institute of Medical Sciences, Delhi, in Jaipur, in the National Institute of Orthopedic Handicap, and in Kolkata, NIRTA, National Institute of Rehabilitation, Training and Research, near Bhubaneswar, NIMHANS, Mental Health and Neurosciences, that's in Bangalore. All these institutes offer training. Apart from that, almost today, because the awareness of this field is increasing, many governments have actually instituted posts and teaching posts in various government hospitals, and courses are being introduced. We are about 500 plus strong in this country, and now we are getting a lot of inputs from abroad and a lot of people coming in, and this is a field where we need to be on the cutting edge, not just with the medical but also the biomedical and bioengineering areas, because lots are being done. You must have heard about the bionic arm or a prosthetic leg which has sensors, or pain blocks which are given at the site of the spinal cord, or injections of botulinum toxin to reduce spasticity, or intrathecal baclofen pumps which are inserted to reduce spasticity. So management of the disabled and now called differently abled individual is it's a multi-speciality, multi-skilled operation. So it's not just a prescription of baclofen. You need to titrate the dose, the spasticity has to be controlled, the person needs to be given physiotherapy, he needs to be given exercises and gait training. The spectrum is really, really wide. So wide that today we find physiatrists specializing. So you have them specializing in neurological conditions, some in orthopedic, some in pain management, others in sports medicine. But a lot of people ask me, is this sports medicine that you're doing? Because that's how somehow it's got aligned to or associated with. But physical medicine is not sports medicine. Sports medicine concerns several other aspects. A part of physical medicine is there in sports medicine, it's there in neurology, it's there in orthopedics. In fact, during our postings, I think possibly this is the most varied number of postings that one ever gets to do. Our diploma those days was 3 year, was the only 3-year diploma, and in the second year, you won't believe it, we went to neurology, we went to neurosurgery, we went to chest diseases, we went to orthopedics, we went to rheumatology. So there are any condition which leads to disability. We all know there are 5 types of disability. The locomotor, hearing and speech, visual, mental and psychiatric. So there are these 5 types of handicaps. We, the physiatrists, the specialists in rehab, get to be exposed in various departments. And once we assimilate all the inputs, we chart out the rehab process for these patients accordingly. As I told you, today it is it's developing by leaps and bounds because biomedical engineers have come into the field, and we need to integrate with them newer and newer concepts, newer instruments. So gait training is a new field. Retraining patients with spinal cord injury is a new field. Orthotics, where we fit calipers, is taking a quantum leap. There is, however, a very social and, let's say, philanthropic angle to the whole field also, which I consider very satisfying, and that is what I keep doing whenever I get my spare time, which is almost today every weekend.
How much of this technological advances has actually penetrated into a place like Chennai?
In rehabilitation, I'm sorry to say very little. We have kept pace with several areas of advancement in medical technology, but in rehab, there is a lot of need and a lot of requirements still that we have to implement in rehabilitation.
So if somebody wanted a bionic arm, they still have to go abroad
It's
for
still in
that?
the area of research and extremely expensive.
Any other technological advances you find is going to benefit our patients?
Yes, today we have endoskeletal prostheses, for example, which were not there earlier. We have prosthetic feet, which cost even lakhs, and they are all imported. We have good rehab departments where you have computerized gait analysis. You have you are able to do studies on how to improve gait. You have good physiotherapy departments, good orthotic and prosthetic workshops. All these are in the process, but let us say we are still not on the cutting edge in rehab technology still.
If you had to advise anybody to go abroad, what would be your university of choice?
Stokes Mandeville in Britain is a very good place to do spinal cord injury. Singapore, Tan Tock Seng, I have visited. They have a good neurosciences, neuro rehab program. In the United States, there are several centers. Cleveland has a good center. And of course, the concept of rehabilitation is very well advanced in the West. So centers in Austria, centers in Germany, Israel, all these centers there's a lot of cutting edge research going on there.
What would your advice be to a young doctor who would be interested in doing rehabilitation medicine?
Get the basic degree here, because we still have a lot of patients with residual disability. If you take even management of poliomyelitis, rheumatoid arthritis, there are so many conditions which need rehab. So the basic qualification here, and then probably get qualified abroad and come back and spread their expertise here.
Now you've established a center. It must be quite tough to actually have a center of your own. So how did you go about doing it in terms of getting funding, then how to spread the word? Is there any advice on that?
Well, I've been asked this question often. This basically, physical medicine has always been thought that private practice in physical medicine has its own limitations. There's always this perception. But when I started, I decided to have a pain management clinic first. So we have a dietary